Tonight's program is about cognition and multiple sclerosis. My name is Stuart Schlossman. Most of you all that are online already know that I too have MS. I too have memory issues, which is why this is a great topic for me. And yes, this is an event that is solely provided by our organization, MS Views and News. Tonight, we have Dr. Brian Steingo. And Dr. Brian Steingo is a fabulous doctor here in Southeast Florida. He's a fabulous doctor everywhere, right? But he practices here in Southeast Florida. And Dr. Steingo is online with you all tonight to speak about the topics that you see right in front of you. I'm going to let him take it away.
Well, good evening, Stuart, and everyone who's joined us. Thank you for joining us. My name is Brian Steingo. I'm a neurologist in Sunrise, Florida. My practice is limited treatment of people with MS. For those of you who heard me do this on many occasions beforehand, you're aware that this is a very topic of great importance to me. And I always introduce it by talking about the land of MS. And then we are going to see where our topic tonight fits into this general discussion of the land of MS. Next slide, please. So this is the land of MS. If you look at the top left of this slide, you'll see it says Introduction to MS. And this refers to when the diagnosis of MS is made. At that time, it's very important that your neurologist educate you to tell you about the type of MS that you have, and also to give you expectations. One of the biggest problems I see in my practice when people are referred is that their expectations are not really good at all. So explaining expectations to you is very important. Now, once you've been introduced to MS, you then enter into this big circle in the minute here, which I call the circle in the middle, which I call the land of MS, and I've called it the control tower because theoretically everything is meant to happen from there. And in the control tower, there are important people sitting who are more important than me, and that's yourself, the person with MS. You may sometimes see that abbreviation that some people use now in their writings when they use the abbreviation PWMS, which stands for people with MS. And so in the land of MS, there is yourself and then your team that is with you. Now, if you look to the right-hand side, you'll see the symptom tower. And why do I call it a tower? Well, the skyscraper in this land of MS that we're trying to develop as a modern city is that symptoms of MS, there are so many symptoms that we need a tower to deal with them all. We're not going to talk about those today. But if you look further down on the right-hand side, the next department you see is what I call the Department of Cognition. And that is because memory and cognition are such important symptoms of MS, and we're going to spend time dealing with those symptoms. I want to emphasize that I'm going to speak to you about cognition from the standpoint of a neurologist. Often as someone who has a memory problem, you might see a neuropsychologist, but I'm going to speak to you about it from the standpoint of the neurologist, where we're incorporating management of your cognition with part of management of the entire MS. And then as we go around the circle of the land of MS, you'll see other areas that we could enter at any time and spend time with. But today we're entering the building that says Department of Cognition, and that will be our emphasis. Next, please. So this is our topic, MS and cognitive dysfunction, a very important symptom of MS. Next, please. I want to make 2 points over here on this slide, which are actually interactive, which is to firstly say that cognitive symptoms may occur independently of physical symptoms. What that means is that we see some people that have many cognitive symptoms, poor memory, but physically may have very mild symptoms. And secondly, that the degree of physical impairment can be unrelated to the degree of cognitive impairment, meaning someone could have severe physical impairment, but not have very much in the way of cognitive impairment. So these two things can be separately of great importance, with one being mild and the other one being severe. It's very important to recognize. Although, however, as you'll see on the next slide, in many cases the two do go together. So here is the next slide, and this slide over here. I put all the references at the end of the program, and all the attributes of where these slides are taken from. All of that is at the end of the program. It's certainly not a slide put together by me. It's excellent work that was done. And at the end of the program, you can see the references. So what this slide shows is that the type of cognitive impairment by the type of MS. So let's look at the left-hand side, and you see first on top, clinically isolated syndrome. That is someone that has their very first episode of MS. They have been newly diagnosed. And now let's move over to the right side, and you see in that last column, it says CI prevalence. And what that stands for is cognitive impairment prevalence. That means how many people with that type of MS have cognitive problems. So let's look again at clinically isolated syndrome. Someone is newly diagnosed, maybe their first episode, and 34% of those people already are found to have some cognitive impairment. Now we move to the next line. The next row is relapsing remitting MS, and going across the right-hand side, you'll see that 44% of people have cognitive impairment. Next, if you look at the next row, you'll see that with secondary progressive MS, almost 80% of people have cognitive impairment. And finally, on the bottom row, primary progressive MS, back to the last column, it says about 90% of those people have cognitive impairment. So although I previously told you that cognitive impairment and physical findings may differ, you can see that in general, as the course of the MS gets physically worse, and as people have more progression of their disease, their cognitive, in general, also cognitive function may also decline. Overall, if you look at the very bottom line on this slide, it gives a number of 46% in this study, but different studies give different amounts of saying between 40 to 70% of people with MS have some cognitive decline. So we're dealing with a very important symptom. Next, please. Now, from a standpoint of a neurologist, when you have any symptom of MS, and this includes cognitive dysfunction, we need to be sure that your symptoms are coming from MS. The last thing that we need to do is to mistake a symptom from something else and miss a diagnosis, blaming it on MS. And everyone knows their experience, and I often see this, is that everything that someone has, whatever it may be, is attributed to MS, and we know it's not from MS. Something else may cause the symptom. So let's look at some of the things that can cause memory loss in MS. Number one, of course, is MS. People with MS can have cognitive dysfunction because there are lesions in different parts of the brain, so people with MS can have cognitive dysfunction. And in a little while, we're going to talk about specific aspects of cognitive dysfunction. Now, number two. Number two is other symptoms that you might have, which could be from your MS or unrelated, that also may cause memory problems. So depression, fatigue, sleep disorder, all of these things can impact the memory. Can you imagine if someone doesn't sleep well, they're very fatigued, they can't concentrate? There's interaction between all these symptoms. So these symptoms need to be managed in their own right. Number two, next slide, please. Number three, what else can cause cognitive problems in MS? This is a very important group. Again, more detail to follow, but medication effects. There are medications that you might take that could make you feel slow, lose concentration, have difficulty thinking. Now, I listed over here, the first comment here is on medications called anticholinergics. Now, these are commonly used medications. They can cause dry mouth, low blood pressure, confusion, memory problems, and agitation. Now, where are these anticholinergic medications found? In many MS medications have anticholinergic effects. Antidepressants can have anticholinergic effect. Anti-seizure medications may cause memory problems. Bladder medications, medications used for spasticity. So there are a whole host of medications, the anticholinergics and all the other medications you see listed below, which include some anticholinergic effects. All of these can affect the memory and should be looked at. We should always look at someone's medication list, which is why it's so important for you always to detail your list of medications for us when you come for your visit. And then finally, number four is other conditions. That means other conditions cause memory problems too. This becomes a more important topic in our older MS patients. So the average age of an MS patient in the US is over 50. Many people quote it as 55, meaning half the people with MS in the US are over 55 and half may be under. But older MS patients may be prone to other conditions. So, for example, if you have a 65-year-old patient that is in an age group where Alzheimer's disease occurs and they have memory loss, we need to evaluate that and make sure that there's no other cause, memory loss, or that this person is having strokes that is causing them to have small strokes in their brain, hardening of the arteries, also causing memory problems. So we always need to be aware of and consider other conditions as well. Next, please. I wanted to define this for you The meaning of cognition, when we say what is cognition, meaning that it's all the mental processes that the brain performs, of which there are many, and I've listed two common ones here, and I wanted to just mention them in brief because they're very interesting actually. And if you look under memory, you will see the first thing listed is procedural memory. Now, what is that? That's the kind of memory of doing something that you're accustomed, riding a bicycle, swimming. So you might have poor memory, but if we put you on a bicycle or throw you into a swimming pool, you'll be able to do those things. That is memory that is ingrained, procedural memory. And this is the type of memory that is least likely to be affected by MS. The next type is called declarative memory. This is learning facts, learning information, learning from books, learning from TV, learning from newspapers, learning new facts. And then finally, there's prospective memory. This is going forward memory, remembering to remember. What do you need to do? What things are coming ahead? Prospective memory, which certainly can be involved in MS. Now, all these types of memory, what's the importance? We said procedural memory is not commonly affected, but then when we're addressing how to help someone with their memory and to try and deal with it, it's important to know something about the type of memory involvement. And then we have problems with attention and concentration. And this is all listed over here and will be archived later on the website. But people can have different kinds of attention problems. Sometimes they can't deal with competing distractions. Can they switch from one task to another? How do they deal with distractions in their background or dealing with multiple tasks at the same time? Can they maintain concentration for a prolonged period of time? These are different types of attention problems that I've listed over here. Next, please. So we spoke about memory, we spoke about attention, but there are other ways in which cognition or mental processes in the brain can be affected. And this is information processing. How do we process information? We acquire it, we store it, and then we have to retrieve it. So information processing, complicated, often affected in people with MS. Executive functions, planning and organization. And I'm listing all these things because when we talk about rehab, each of these things may be the things that we address. Solving a problem, visual and spatial perception, and language use. And we're going to speak a little bit at the end. I'm going to go into a little more detail about speech and language, because these are so important. Communication is such an important part of the human existence. So what are the things that happen? We've told you all the breakdown of how the brain is affected. As a result of all those changes in the brain, what happens to the person with MS? They have problems with processing speed. They have problems with their verbal memory, both the immediate and the delayed, and the visual memory. So verbal and visual memory are impaired, and working memory. And then there may be problems with visuospatial perception. Now you can start breaking all of these down and see how they interfere in your daily life, and we'll go into some of this in a minute, how they start to impact on your daily life. Think about driving, for example, and then concept formation, and again, language and fluency, ability to communicate. Next, please. So what is the effect now of all these things we've said about that can happen to people? How does this impair their daily life? How does cognitive dysfunction impair their daily life? They have difficulty multitasking. How many times have people said they cannot multitask? And this is part of our rehab. Avoid multitasking. Do one task at a time. Even walking and talking, it could be multitasking. So pay attention to the task at hand. Leave a task at a point where you can come back to it. Cognitive fatigue. And how many people find that they get tired? Brain fog. You've heard the term many times, brain fog, cognitive fatigue. And then executive function, getting something done, having the ability to complete a task, to plan a task, to organize a task, and abstract reasoning, attention and concentration. So these are all the effects of cognitive impairment on daily function. I've broken this down right at the beginning. We started out and said, what are the effects on the brain? How do these effects on the brain affect your overall function? And then how do they affect your daily function, which is what I listed here. And what's the effect now of what's the actual effect on your life of these impairments of daily functioning? It affects social relationships. It affects personal relationships. It affects work performance. It affects driving. It affects self-esteem. People say, I've become stupid. No, they haven't, but they feel that way. They can't drive. The loss of a most fundamental activity that a human can do. So you can see that the impairment of all these attributes has very deep effects on our life. Next, please. Now we're going to go into a little more detail of those things. I'm just explaining to you some of the things we see. So the effect on social and personal relationships. A person may have difficulty expressing thoughts. They cannot comprehend or track a conversation. They cannot remember a recent discussion. In speaking to someone, the person may become frustrated. Have you seen people get frustrated, irritated, because they say, well, I've told you that before. Don't you remember? I told you that already. Why don't you pay attention? None of those things are true. It's just that someone has a true problem. And yet people around them may not understand this, and we'll talk about how to deal with this in a little while. They may be frustrated, irritated, avoid a conversation. So will people sometimes tend to stay away. Friends may drift off. I can't talk to them because they can't get to the point. They go over and over everything. They forget things. And this ultimately can lead to social isolation. So we need to try and prevent each of these steps or manage them to make life better. And then family roles. Now within the family, a loss of function. It may be the breadwinner or the housemate, somebody who is very active in the home. Loss of executive function, loss of work. The person who's contributing, an important contributor in the household budget, loses work. There may be a change of roles in the home. And then not driving. Why? Because of physical problems maybe and cognitive problems. So what does this result in? A shift in relationships, a loss of respect, resentment. You used to do this and now you can't do it anymore. Try harder. You're lazy. No, none of the above. But this is what we see. Very important that people understand what's going on and what this leads to if it's not addressed properly. A loss of independence. And ultimately, divorce, a breakdown of the family. And this is all from cognitive dysfunction. And the risk of this happening with cognitive dysfunction is equally or greater than the risk of this happening with physical dysfunction. The next one is work performance. Impaired cognitive skills are a major cause of people leaving the workforce early. So we know that one of the greatest causes of people losing their job and stopping work is cognitive. In young people that stop working, it's more often cognitive because cognitive failure cannot be replaced. Physical failure can. If someone has difficulty walking, you could get a scooter or a chair. They can drive maybe. They can replace it. But there is no such replacement, adequate replacement for inability to perform cognitively. And the net result of all of these is a loss of self-esteem, of people thinking they're stupid, not worthy, and none of those are true things. But you can see from this particular slide that all the things that I've described before that happen in the brain with cognitive dysfunction have led to all these serious consequences. Next, please. Now, the next question is, how do we assess cognition? Next slide, please. So, the best way to assess cognition is to do a neuropsychological examination. That is a detailed exam done by a neuropsychologist that could take hours, many hours, and a very, very difficult, fatiguing test. So we often ask the neuropsychologist, when we're dealing with a person with MS, to break the test up. A person with MS has a difficult time doing an 8-hour test in one day. So we would say, this person has fatigue. Please break up the test and do it, say, over a number of days, maybe at least 2 days. So that is the role of the neuropsychologist, and that is the most detailed testing. And this testing, to me, has greatest importance when we're trying to assist someone with disability. The next test that I listed here is the Symbol Digit Modalities Test, only because this is a very simple office test that we can do. And we're using this test now in a lot of clinical trials. Now, if you look at this, what I've copied in over here, And if you look at the top part of it, look at this white rectangular structure. And if you look at it, you'll see that there's a symbol, and underneath the symbol, there is a number. And at the bottom is the test, where underneath each symbol, you need to add the number. And then we see how many of these symbols you can appropriately put the number in the space of, say, 90 seconds. That's a very easy office test for us to do. That only takes, say, 90 seconds. There are other cognitive tests that you see I've listed. I only put the names in case you come across them, like MACFMs, which are tests that are assessing cognitive function MS, or these other tests. They take longer, but they don't take as long as the neuropsych exam, and they may take 90 minutes or 20 minutes, different tests, different amount of time, different validity. The common tests used by neurologists listed in number 4 are mini mental state exams. Now, the problem with these, which are commonly done by neurologists, often, for example, in screening for other diseases, even like Alzheimer's, is that they lack an index of processing speed. And this is one of the cognitive aspects of MS that is lost, was processing speed. And these tests don't measure that very well. So they're not ideal for MS. Someone could use them for screening and monitoring, but they're not ideal tests for MS. Some of the other tests above are better tests for us to do. So that's the neuropsychological and memory evaluation that I've spoken about. Next, please. So now we're going to talk about how we manage this situation, this difficult situation. How do we manage this? Next slide, please. I wanted to point out over here about the invisible symptoms of MS. A good time just to mention it is that many people with MS have visible symptoms that are not apparent to an outsider. And these symptoms are very important, as we've just shown before. These are symptoms that can affect relationships and respect and confidence. And people can't see. Other people on the outside might not see these symptoms. They might not see the internal frustration or fear. What about fear that someone feels? And people will actually look at someone and say, "You look so good." And that's why the MS Society has that brochure that says, "You look so good." And it's very important to remember that memory could be a symptom like this that people might not always be aware of. People often can cover up for their memory problem. And so be very aware of these invisible symptoms of MS that are often very disabling. Next, please. So how do we manage cognitive impairment in MS? And the same principles, for neurologists, the same principles hold here as the very early slide that I showed you, which is that there are many things to consider. So the first thing is treat the MS. If someone has MS, we want to treat the MS. We're very fortunate now. We have 20-something drugs that we have to treat MS. We call them DMTs, or disease-modifying therapies, or disease-modifying drugs. Today, this year, is going to be an anniversary. The first disease-modifying therapy approved for MS was beta-seron in May 1993. Beta-seron is turning 30 years old this year. And, you know, we have many medications now and more coming along. So treating the MS, just intuitively, we think if we can treat the MS, we're going to do something to slow down the worsening of cognitive function. Also, we know from studies we should treat MS early. So it's very important. Treat early. Don't wait to see what happens. I think most neurologists who treat MS will never have a philosophy of saying, let's start something mild and wait to see what happens. We want to start out treating this and getting hold of this disease from the beginning. Number 2, optimize the treatment of MS symptoms. So whatever symptoms there are, and we referred to some earlier, depression, fatigue, spasticity, whatever symptoms there are, treat the symptoms early that may be contributing to the memory problem. Number 3 and number 4 are compensation strategies and cognitive rehabilitation, which might often be administered by a group of people, and I'll mention this in a minute. And then physical exercise is very important. There's good studies that have shown that physical exercise is as important for retention of memory as is cognitive exercise. Now, finally, I put in this heading of medications and supplements for memory. And there's no evidence for these. There's no evidence that these help. There is, for example, on TV, Prevagen that's advertised all the time. There is no evidence that it helps MS. Nothing. I don't think it does any harm, but there's no evidence that it helps. Other drugs have been tried for this that are used for Alzheimer's disease, such as Aricept. Again, these were small studies that were done, and there is no good evidence that these medications help for the memory of MS. So we have nothing that is directly going to help the memory. So steps 1 through 5 on this slide are the very important steps. Next, please. Now, this is, what are the effects of the disease-modifying therapy on cognition? What's interesting here is the very first paragraph that says there is some evidence of a correlation of brain atrophy. So if we see some shrinkage of the brain, that person might be more liable to get a memory problem. And this could be the whole brain, the volume of the entire brain. Or it could be just loss of the gray matter of the brain, or thalamic atrophy. The thalamus is a part of the brain that is deep inside. It is also gray matter deep inside the brain. So different parts of the brain can atrophy and shrink and may correlate with a memory loss. However, in clinical trials that we've done up to now, we don't usually look at memory. We look at relapse rates, disability progression, the MRIs. We haven't really looked at cognitive data. There are two studies that were done, two reports that were done, looking at many studies. And these were one of these reports looked at 87 studies, another one looked at 47 studies. And they said we don't have a lot of evidence as to what these drugs are going to do to help memory. We don't have a lot of evidence. And we certainly don't have enough evidence to say that if memory is the only problem, we should switch from one drug to another. We don't have that evidence yet. But it's coming. It's coming. Next slide, please. So what I'm showing you here is some reports. Now, let me point out, I'm not recommending these drugs as drugs you should take for your memory. I'm giving you examples of studies with some of the drugs that have been done that have shown memory benefit. So, for example, with Ocrevus or ocrelizumab, they did a study with progressive patients, and they said that with therapy, cognitive function in these patients may be stabilized. And then they did another study which showed that there was a reduction in the thalamic volume loss in the patients that took this drug compared to interferon or placebo. There was less loss. There was less shrinkage of the thalamus. The second one I'm pointing out here is teriflunomide, in which they also showed that during their study that if people were on the drug, there was slowing of atrophy, even in the whole brain or the gray matter. And finally, on ozanimod, another drug, compared to interferon beta 1A, there was less loss of the thalamus and the gray matter tissue over 12 months. So these drugs, compared to the placebo drug, compared to the placebo or the comparator drug, slowed down the loss of brain, slowed down the decrease in the brain volume. So we have some evidence that these drugs are working with cognitive function, but we don't know yet, is one better than the other? Not enough for us to switch from one to the other just based on this. But this is exciting information because as new studies come about, there's more and more attention being paid to cognitive aspects and how we can slow down cognition even more. Next, please. This is just amplifying something what I showed you earlier, which is drugs used to treat MS symptoms, to show you how many of these are in those families. Let's look at fatigue. Amantadine is used for fatigue. The other ones are stimulants. We may use those to help people focus and pay attention. Let's look at depression. Many of these drugs, antidepressants, can affect cognition. Some of them have anticholinergic effects and can actually make memory worse. Drugs used for spasticity, baclofen, tizanidine, can make people very sleepy. A lot of the pain medications, gabapentin, carbamazepine, if you look at the next list, can make people very sleepy. The bladder medications can affect memory. So as we go through this list, we see many interactions between these drugs that we always need to be aware of. Next, please. A brief reference over here to what we call polypharmacy, why we always need to know about what drugs you're on, because people could be on multiple drugs from multiple different physicians, and their drugs may change over time and formularies change over time. So we always need to be aware of what someone is on before we start to see more and more interactions and effects on other aspects like cognition. Next, please. So this is management of cognitive impairment, and there's two ways we can do that. This is cognitive compensation. One point that I want to make on this slide is advise people up front. It's important to tell people up front that they may need to repeat something. I think they appreciate that. If someone says, I have an issue maybe you need to repeat it. And then take information in manageable accounts. Use assistance, notes, phones, online, calendars. Try and limit interactions. Organize tasks. Put things in the same place. Put your keys in one place. Put common things in one place. Take on one task at a time. Manage fatigue. Rest when necessary. Next, please. and work accommodations. And we can help you. A neurologist can help you with this work accommodations. Work in a quiet environment if possible. Limit noise, limit distractions. If you need work accommodations, you ask your neurologist. Make a note of them. We write you a letter to say what accommodations you need. Limit distractions. Make comfort a priority. Be comfortable at work. The right temperature, the right seating. Control distracting thoughts. If there is some distraction, change the activity, relax and breathe. Don't be distracted by the need to get water or a snack or something. Have those all available. Make yourself in a comfortable, cool environment. Next, please. And this is cognitive rehabilitation. I'll basically say that there are two approaches. I see time is going to run out soon. There's two approaches to rehabilitation. It's either to restore or to compensate. Restoring is difficult. Compensation is much easier. And compensation, basically what it says is that it is not necessary to improve an ability in order to improve a function based on that ability. So this applies physically as well. For example, if someone is going to work but they have great difficulty walking and they use a wheelchair, they've compensated for that ability. They're still able to function very well, but they haven't improved the ability to walk, but they've compensated for the ability. So compensating is very important. And at the bottom, it talks about the cognitive reserve, which is basically keeping your mind processing and working using music or artwork, newspapers, games, and hobbies. Next, please. Cognitive rehabilitation. The people that are involved in cognitive rehabilitation would be your physical therapist, again, stressing physical exercise, the occupational therapist, the speech language pathologist, and the neuropsychologist. All these people might be part of the team. I should put the neurologist here too, because we have to make sure you're getting the right medications and the interactions. And then rebuild your skills. This is talking at the bottom about some techniques like self-generation. What that means is that if you're trying to improve a skill and you're trying to get out a word, it doesn't help when someone else, you say the word's on the tip of my tongue, I can't get it out, and someone else says it. It's much better if they are people that are going to give you the opportunity to say that word. Spaced learning means if you're learning something and you want to repeat it. So you say something, you read a paragraph, don't repeat it right away. Wait 5 minutes, then do it again. Wait 15 minutes, do it again. So don't do them back to back to back. Have some spaced learning. And finally, stored memory is to take a particular item that maybe have forgotten and associate it with a visual, for example, something visual. So you have some other way of remembering that brings up some way of remembering it. Cognitive rehab. I'm going to end with the MS and speech dysfunction. Communication is very important to everyone. And what is speech? There are two aspects to speech over here. The first is the responses and the thoughts from the brain. So firstly, in our brain, a thought arises that we then want to express to those around us. And in addition, sometimes people speak to us and we respond. That's all part of speech. And finally, when we have a thought, we now want to express it, and that is part of the physical action to produce sound, which is complex, which involves lips and tongue and vocal cords and all the structures around our mouth and throat that are producing this sound. So that is what speaking is about. And the next slide shows you the kind of speaking. The first type of speaking problem, the more common type of speaking problem in MS is called dysarthria, which affects the production of speech. All those items involved in speech production that can be impacted. So muscles could be very tight, very stiff, much like we're feeling muscles in our body from MS. We can have stiff or tight muscles. There can be loss of control or a combination of these. And what does this result in? Slurred speech, slow speech, low volume, hoarse speech, raspy speech, and pitch changes. So this is dysarthria, the more common type of speech dysfunction. It adds to what we said earlier about people having some trouble remembering and expressing themselves, and people being impatient about when someone is trying to express themselves, not only by virtue of their thoughts, but also that they can produce the speech. Next, please. A much less common type of language disorder in MS, much more commonly seen, for example, with strokes, is dysphasia. And that is where someone cannot find the word. It might be in their mind, but they cannot find it, or the wrong word comes out. It's at the tip of my tongue. So that's dysphasia. Cannot find the word. And then That is called expressive dysphasia. Then we have receptive dysphasia, where there's a difficulty understanding what others are saying. It's receptive. The words that are coming in, the messages that are coming in, are not getting processed properly. And therefore, the response that someone might have to that might be inappropriate. So it might lead to inappropriate responses. So that's what I want to say about speech. And next, please. And next is the final slide, which says, or second penultimate, yeah, this one is the final one, is all the references I mentioned to you. But on the one before this, I wanted to say to you how important it is to have communication with your healthcare team, with your neurologist, because I strongly believe that we should have the shared decision-making. Knowledge is power. If we can discuss things with your healthcare team and with yourself and your support team, whoever may be involved, it's important that everybody is together in this. Okay, and that is the final one. And then the final one is the references. That's the next one. Is the references, which everyone is free to look at on the archive eventually.
Thank you, Dr. Steingo. Thank you very much. We have a virtual round of applause going here. Can you hear it? I do. Okay, great. Thank you very much. And I want to thank everybody for being online. We do have a lot of people online, so I'm really glad to see this. We have 61 people online right now. That's great post-COVID, right? All right, so we have a few questions about the conversation for tonight. All right, so first topic for tonight, question rather, is how do you differentiate between Alzheimer's and multiple sclerosis?
So as I was pointing out, it's not always an easy differentiation. So Alzheimer's is going to be seen in people with MS, older patients with MS. Typically, that's the kind of patients we're looking at. And then the best way to differentiate really is to do a neuropsychological testing. And the neuropsychological testing helps us in the sense of the pattern. So we're looking at the type of pattern, which parts of the brain are involved. So we know to some extent about certain parts of the brain that are involved with MS. I listed a lot of things with MS that are involved. For example, certain types of memory changes, and the pattern of memory change with Alzheimer's could be a different pattern of memory change, for example. So there would be some differences between the type of memory that's involved. It could be the age of the patient. It could be the family history. So those are some things we put together. But ultimately, one of the better ways to do it is with neuropsychological testing.
Okay, thank you for that. If a person is getting frustrated because they are not able to pay attention to certain things because there's just abstract noise going on in the room, is that part of a cognitive decline?
So in terms of, we spoke earlier on about different kinds of attention that people can have. Some people have trouble with, so some people can have the question of what type of attention people have. Some people have trouble when they get distracted. Other people can multitask. Everyone's different. So a lack of attention and lack of concentration is definitely part of cognitive dysfunction. It's why I spoke about some adjustments that can be made, like in the workplace. Try and be in a quiet environment. If you're with people that are caring people, you could, move aside, sit in a quiet spot, sit in a quiet, comfortable spot, try and get away from the noise. If it's something that somebody needs help with at work, we have medication. Some of the stimulants will work to help people focus. But I did put in that one slide some of the recommendations that we have to try and help people remain in the workplace. It's very important to have accommodations. So if someone's having trouble at work with attention and concentration, it's very important. So it's very important that they have accommodations, and they should ask us for them, and we should write about them, because that would enable them to stay in the workplace much longer if they're in a quieter, cooler environment, their comfort zone around them with their snack, with their water, so they don't have to get up and go into a noisy area and be in a quiet area. So we would certainly write that. Be in a quiet area, not where there's a lot of noise. That is more difficult to deal with.
Dr. Steingo, going back to something similar that I just asked you for somebody, when a person goes into like a supermarket or any store, and there's just volumes of things around in that store, and they get confused as they're walking around in the store because they're getting like brain overload of what's going on around them. What can you say for people like that other than get out of the store?
So I'm going to refer again to the slides I put up, but I'm going to say certain things that are very important that help people a lot. So firstly, we are saying to people with MS that they should not multitask. Do one task at a time. Right. So next, following that is planning and organizing. Planning and organizing is very important. If someone is going into a store and they have trouble walking, for example, use the scooter in the store. It takes away some of your pressure. You don't have to worry about the car. You don't have to worry about pushing a cart or people bumping into you, because they tend to do that. They're always in a rush, of course. So use a scooter or use the cart. Use something that is easy for you. And then planning, organizing. That means what as well? Make notes, make lists. These are very important things that take a lot of pressure off. So going to the store means you go and you're well organized. You're planning it. You're planning how you're going to travel around the store. Everything's very planned. And then, of course, it's also a good time to go to the store when it's quiet if you can. And not everybody can. It could be working or some other reason. But if they can, the best time to go to the store is when it's quiet. I mean, what's a quiet time in a store? Maybe in the middle of the day. I don't know because I'm working, but in the middle of the day might be a quieter time. So go at a quiet time, plan and organize. That's the kind of advice we would say.
Okay, thank you for that. A person writes, how often should you do a neuropsychological test?
At the beginning to diagnose it, if we need it. So if someone says they have a significant memory problem, I may do the test or I may not always do the test, because I can do some baseline test in the office that shows me that there's a problem. And then what I'm going to do, the most important thing I'm going to do for them is I'm going to help them with strategies. And I'm going to refer them to the right people. We have a team of people that could help them. It could be the occupational therapist. We're going to get an occupational therapist, send them into your house to show you ways of dealing with this so you can deal with this better, so you can be better organized. Organization and planning, so your keys are in the right place. So your clothes is in the right place. So you don't trip over a rug. So we'll send an occupational therapist in. We can have a speech language pathologist if there's problems with communication. We might send you to the neuropsychologist for cognitive rehab. And then the very important physical therapist to teach you exercises. And I'm stressing exercises that you can do, not that someone else wants to do. Customize the exercises for you so you can do them comfortably, maybe seated or in some safe way. So there's all these different aspects that I think the neurologist should be the leader and direct you where to go. But there are several different types of people that can assist us in helping someone.
Okay, thank you for that. Next, the person is asking, do plaques on the brain look different with MS versus Alzheimer's?
Alzheimer's is not characterized by any specific plaque. You cannot look at a brain scan and say, well, this person has Alzheimer's. So firstly, there are many, many causes of plaques or white spots on the brain. It's probably, in the tens or hundreds of causes of plaques or white spots on the brain. So when we look at someone with that we suspect has MS, we have to make sure there's nothing else causing their white spots. For example, migraine could cause white spots in the brain in a younger MS patient. Whereas in an older patient, we could see hardening of the arteries cause white spots. So if you have a patient who's 70 years old and they have white spots, it could be from hardening of the arteries or small strokes, not necessarily MS. So there are no spots that tell us in the brain that someone has Alzheimer's. There are spots that could say they have hardening of the arteries, but an MRI scan is not a scan that we can use to diagnose MS, to diagnose Alzheimer's disease.
I got it. Thank
you. We
you.
can use it, of course, to diagnose MS. We can see specific things on the scan that tend to suggest it's MS, but not Alzheimer's.
Okay, thank you. Next person writes, I'm in limbo. When I get anxious, I stutter, and I cannot organize my thoughts. How should I react?
So it's kind of what I've said before about having a team effect. So for anxiety, we try always with any symptom that someone has, such as anxiety, to treat it without medications. What do we use for that? We can teach people meditation techniques. So some people obviously can respond to that much better than others. Mindfulness, the ability of someone who feels anxious to step back, step out of the situation, step back. I always say that there's 2 steps that we can take when we have a specific situation that occurs. Sometimes you might have to take a step forward, like exercise. Exercise doesn't happen unless you take that first step and go forward. But when you're under pressure, stress, anxiety, it's always good to take the step back and then look around and say, okay, what is this? And to sit down. And then once you sit down, you start to use techniques, and those techniques could be things like meditation, mindfulness, and then we may get people that are trained to help you with this, for example, such as a cognitive therapist or a therapist, to help with the techniques to try and teach you how to deal with this anxiety, which can be a very serious problem. If those fail, we sometimes use medications. I think medications are necessary in some people. I've seen patients that have told me their primary care doctors won't give them any medication because they're going to get addicted. And I said, at the end of the day, it's your quality of life that we've got to work on. So let's try together. If you need something, you need it, but let's also try at the same time to do all the other techniques as we've spoken about.
Okay, thank you for that. All right. For all those that are asking just general questions about multiple sclerosis, again, tonight's program is not about this, but I just want to let you know that on March 18th, we're doing a summit with multiple speakers, and at that summit, the very first presentation is about just MS 101. All right, so for all these types of questions that you're asking tonight that I'm not going to be able to ask, that's the program for you to be at. It'll be virtual, it'll be in person for those in the Atlanta area. You can go there and watch in person, or you can see this virtually. So you all have information about that. We send it out all the time. And now I'm just going to continue with the last few questions. All right, next person writes, is it possible that spasticity can affect cognition and focus?
So my answer was yes and no. And by that I meant the following. Spasticity is a condition of the muscles. It causes stiffness of the muscles. The manifestation of his muscles are very stiff. Related to that is spasms of muscles. So these are muscle phenomena. And why did I say yes? Because the medications that are used for spasticity can affect cognition. So, for example, what do we use for spasticity? The commonest medications we use are baclofen and tizanidine. Both of those may cause drowsiness and sluggishness. So if someone has memory impairment or borderline impairment, and then you make them more sluggish or sleepy, that's what those medications can do. So not a direct effect of spasticity, a direct effect because of the medications that are used.
Okay, thank you very much for that. Next one is something that I have no idea what the person is asking, but I'll ask you anyway. You spoke about the thalamus. I'm wondering what your stance is on DBS for a person with MS that has damage there.
Yeah. So everyone knows about the term the white matter of the brain. MS has always been considered to be a disease of the white matter of the brain, which if you look at a brain scan, most of the scan is white matter. The gray matter is a thin layer on the outside of the brain, but there's also gray matter deep inside the brain. So that's where the thalamus comes in. It's a structure deeper inside the brain that controls many functions. Very important center in the brain is the thalamus. So that is, we've seen that there may be some correlation between shrinkage of the thalamus and atrophy. Deep brain stimulation, that has been used in people that have movement disorders. That is the only effective use of deep brain stimulation that I know of. Mostly that applies to people with Parkinson's disease or certain types of tremors. It's been tried in MS tremors as well. Because MS tremors are so complex, it's definitely less effective for treating MS tremors. So DBS or deep brain stimulation, mostly, to my knowledge, has been shown mostly to be effective in treating tremors.
Okay, thank you. All right, next one and the last one that I have for you is about what kind of therapies are there available for people with, I think you might have mentioned it before, but if you have not, what kind of therapies are there available for people to regain a loss of the cognition?
So that I would refer back to that slide.
Let's talk about, they're actually speaking about memory. So what do you have for, what exercises can they do for memory loss?
I mean, so there's obviously a ton of exercises that can be done, many exercises that are recommended for memory loss. I spoke about some of the strategies. I would always recommend people do memory exercises to make it less stressful. The memory exercise should be one that doesn't require timing. A timing exercise can be stressful. So do any exercises. There's games online. There's Lumosity. There's a game called MindPal. There's Sudoku and crossword puzzles and jigsaw puzzles and a bunch of word games that are all very good. If someone sees a neuropsychologist and does cognitive rehab, there's a bunch of mental exercises that they will do. I mentioned before that the exercises ideally should be staggered over time, not repetitively done back to back, but give a little bit of time between them. That's always good for someone to self-generate, for the person that's working with them, to give them a little bit of time to come up with it rather than say, well, I'm going to feed you the word, for example, to do something like that, and also to picture things. So all of it is exercises, stimulating the brain in many different ways, with visual and verbal cues, and by using exercise that use processing as well.
Great. Okay, thank you very much, and thank you for your time here tonight. We are out of questions, so concerning cognition and memory. I guess everybody forgot what they wanted to ask. All right, so that's the joke of it, right? All right, so Dr. Steingo, again, I appreciate you being here tonight. I hope everybody learned from this.
Thank you, and good night to everybody, and thank you.
Great, thank you very much. Good night.